So now we'll talk about the cardiac cycle. Just know that a lot of these events are happening at the same time, but we kind of have to break it down in order to explain what's happening. The cardiac cycle would be all of the events that are happening throughout a single heartbeat. And the heart chambers have to work in a coordinated fashion in order for the blood to flow through the different chambers and then off to the blood vessels. A couple of terms that we want to be familiar with would be systole and diastole. Systole means contraction, and diastole means relaxation. Okay, and the two chambers on top, the atria, act as a unit. So they either contract together or relax together. And the two chambers on the bottom, the two ventricles, also act as another unit. Okay, they either contract together or relax together. But what you do not have would be atria and ventricles contracting at the same time. So if the atria were contracting, that means that the ventricles are relaxing. So we'll take a little example here. So if the right atrium is contracting, that means that the blood is being pushed from the right atrium down to the right ventricle. So this right ventricle would have to be in diastole or in a relaxation phase. And that also means that the tricuspid valve has to be open so that the blood can flow from the right atrium down to the right ventricle. When the right ventricle when it's time for it to contract, its contraction will lead to the closure of the tricuspid valve and the opening. Because of the buildup of pressure inside of the right ventricle, it'll also lead to the opening of the pulmonary valve. So what prevents the tricuspid valve from opening if the pressure in the right ventricle keeps on going up? Well, that is actually the actions of the chordae tendineae. So these fibers are going to hold on to the cusps and prevent them from opening. The same obviously happens on the left side of the heart as well. So the cardiac cycle, the pressures in the heart chambers are going to change. They either rise and fall depending on whether they're contracting or relaxing. And because of all of these pressure changes, that also leads to the opening and closure of the valves. So what happens during atrial systole and ventricular diastole? And that's what we just went over. So atrial systole means that the atrium is contracted, and ventricular diastole means that the ventricle is relaxed. And in order for the blood to flow from the atrium down to the ventricle, that means that the AV valves, the atrioventricular valves, which are your tricuspid and mitral valves, have to open up, while the semilunar valves, which are the aortic and pulmonary valves, those are closed. About 70% of blood will flow from the atria down to the ventricle just by gravity. The remaining 30% would happen due to the contraction of the atria. And now that the ventricle is filling up with blood, that means that the pressure inside of the ventricle will be gradually increasing. Then the ventricles are going to contract. That means that the atrioventricular valves close. And again, due to the pull of the chordae tendineae on the cusps, it prevents those valves from reopening. The right ventricle, or both ventricles, are going to contract, pushing the blood into either the pulmonary trunk or the aorta, so the semilunar valves have to open up, while the atrioventricular valves are both closed. The blood is then going to be pushed, or due to the ventricular contractions, the blood will flow through the pulmonary trunk and the aorta. At the same time, the atria is relaxing, is going through diastole. So, and while the atria is relaxing, that means that it is receiving blood from either the superior and inferior vena cava on the right side or the pulmonary veins on the left side. So I'm going to kind of go over that again using this image. So we went over what the events during atria contraction. So let's go through the events during ventricular contraction. Again, while the ventricles contract, your atrioventricular valves have to shut down, they have to close, and they are prevented from reopening due to the pull of the chorda tendineae. The pressure inside of the ventricles increase, and that leads to the opening of the semilunar valves, pulmonary and aortic, and leads to the pumping of the blood through those corresponding blood vessels. At the exact same time, the atria are relaxing, they're going through diastole, and they are filling up with blood coming either on the right side from the superior and inferior vena cava, or on the left side, they're filling up with blood coming from the 4 pulmonary veins. So you want to be very comfortable in explaining the events, what is happening during each event, which valves are closed and which valves are open. Now, what regulates the cardiac cycle? We really haven't talked about the conduction system, but the SA node stands for the sinoatrial node, and that is also known as the pacemaker of the heart. That is pretty much the battery that provides the electricity for the heart to contract. And since the heart is made out of cardiac muscle, we know that it is under the control of the autonomic nervous system. So it is under the sympathetic and parasympathetic control. It gets both parasympathetic and sympathetic fibers. Those are going to modify the heart rate, and it will respond to different things like physical exercise, for example. So the heart rate would go up during physical exercise. Body temperature. During a fever, our heart rates go up. Fight or flight situation. So these are all really sympathetic conditions. It'll also allow the heart rate to change depending on the concentration of different ions like potassium and calcium. So the parasympathetic impulses reach the heart through the vagus nerve, and those lead to decrease in heart rate. And the parasympathetic supply goes to the SA node and the AV node. The AV node is the atrioventricular node, and that is the gateway where how the action potential goes from the atrium down to the ventricle. The sympathetic impulses reach the heart through accelerator nerves, and those lead to an increase in heart rate due to its action on the SA node, AV node, and the ventricular myocardium. So you will see that the sympathetic nervous system supplies SA node, AV node, and ventricular fibers, while the parasympathetic only supplies impulses to the SA node and AV node. So the ventricles do not get parasympathetic innervation. Now, what happens when our blood pressure changes? Obviously, our blood pressure is not constant throughout the day. It kind of fluctuates. It goes up a little bit and down a little bit depending on the situation. So there is a reflex to keep the blood pressure to regulate the homeostasis of blood pressure, and that is known as the baroreceptor reflex. So just like any other reflex, we would need to have the following parts: the receptor, the afferent neuron, a center, the efferent neuron, and the effector. So the receptors in this case are baroreceptors, and you could tell that from the name. Baro means these receptors are going to pick up changes in blood pressure. And the baroreceptors are very strategically positioned. They are found in the aortic arch. Those are known as the aortic baroreceptors. And it's also found at the bifurcation of the common carotid, meaning where the common carotid artery divides into an internal and external carotid blood vessels. So you can see here these carotid baroreceptors. So those are your two receptors. These receptors are going to pick up any change in blood pressure and take it through the sensory neurons or the afferent neurons towards the CNS. Now we have different inner neurons, and then the effectors, if it's on the parasympathetic fibers on the vagus nerve to your SA node and AV node. That is if you want to slow down the heart rate. But if you need to speed up the heart rate, the effector neurons would be the sympathetic fibers to the SA node, AV node, and the myocardium. So let's go through a scenario where, let's say, somebody has a sudden increase in blood pressure. That change will be picked up by these baroreceptors, the aortic and the carotid baroreceptors, through the sensory or the afferent fibers, will reach the CNS, and then the parasympathetic nervous system will send down impulses through the vagus nerve to slow down the SA node and the AV node. So that will decrease the heart rate. Lowering down the heart rate will lower down the blood pressure. Now let's take the opposite scenario where somebody maybe is dehydrated and their blood pressure is too low. Again, that low blood pressure will be picked up by your aortic and carotid receptors. The CNS will send efferent impulses through now the sympathetic nervous system to the SA node, AV node, and ventricles to speed up the heart rate. That increase in heart rate will bring back the blood pressure back up to normal. And because the sympathetic nervous system also supplies the ventricles, it will increase the force of ventricular contraction. Again, something to help bring that blood pressure back up. Now, we all know that we have produced heart sounds. These are the sounds that you can hear when you put a stethoscope on the chest, and they sound kind of like a lub-dub thing where lub was your first heart sound, or S1, and dub is the second heart sound, or S2. These sounds are due to the closure of the heart valves. So we really do not hear the opening of heart valves. We hear the valves as they shut. Those are the sounds that we're listening to. So your lub, again, is the first heart sound, and that occurs due to closure of the atrioventricular valves that happens during ventricular systole. While the second heart sound, that is due to the closure of the semilunar valves, both the pulmonary and the aortic, and that happens during ventricular diastole. Now, what about a murmur? A murmur is an abnormal heart sound, and that is due to the incomplete closure of cusps of the valves. So now you have blood flowing in directions where it shouldn't be, and that leads to that abnormal heart sound known as a murmur. Now, where do we put the stethoscope in order to hear the valves? They don't really correlate to the anatomical position of the valves, but they do correlate to the mechanics and the direction of vibration of sound waves coming from each valve. So first off, let's identify two different lines on the chest wall. One line is known as the mid-clavicular line, that flows from the mid part of the clavicle all the way down, and it also passes through the nipple. So since you're looking at the patient and it might be hard to identify where the middle of the clavicle is, you could identify that line using the nipples. And there's also a parasternal line, which would be on either sides of the sternum. So these are the two lines that we're going to need in order to identify the different areas. So the best part to listen to the aortic valve, that is known as the aortic area. It is found on the second intercostal space on the right parasternal line. So remember again, second intercostal space means between the second and third ribs on the right side of the sternum, so right parasternal. The exact same space, but on the left side, would be where you would listen to the pulmonary valve. So pulmonary area, or the pulmonic area, is found in the second left intercostal space, left parasternal. Tricuspid and mitral valves are found on the left fifth intercostal space. Tricuspid would be in the parasternal line, while the mitral would be a little bit lateral in the mid-clavicular line. These areas and valves are important for both lecture and lab, so make sure you are comfortable remembering exactly where the different valves are listened to or auscultated on the left side of the body, except for the aortic valve is on the right. Now, the cardiac muscles we already know that they are branched muscle fibers. We know that there are intercalated discs between the cells, and these intercalated discs have gap junctions in order for the action potential to propagate and spread really fast throughout all of the muscles, because again, these heart muscles have to contract as a unit. And we call these functional units, we call them functional syncytiums. And we have two units in the heart. The atrial syncytium, which would be the two atria, and the ventricular syncytium, which are the two ventricles. So again, right and left atria contract at the same time, so these act as a unit, known as the atrial syncytium, and the two ventricles have to contract at the same time as a unit as well. Now for the cardiac conduction system, which is basically the electricity and the propagation of the action potential through the heart. So we basically have these little built-in batteries and wiring system in the heart. That is what the cardiac conduction system is, a group of clumps and strands of specialized cardiac muscle tissue. What is so special about them is that they can either produce electricity on their own, so they can produce their little graded potentials, and they also have the ability to propagate action potential throughout the myocardium. Again, important to know how it flows. So it starts at the SA node, which is the pacemaker of the heart, and then it flows to all of the atria in order for it to contract as a unit, so your atrial syncytium. Then we'll gather these fibers through junctional fibers, and then it has to go from atrium down to the ventricle, over through the AV node. There is a little pause at the AV node, and that pause allows for the ventricles to fill up with blood, with enough blood. And then through the AV node, the electricity will go down to the AV bundle, which is a very short bundle that will then branch into a right and left bundle branch in order to spread the action potential to both the right and the left ventricles. And then we have Purkinje fibers that will take the action potential throughout the ventricles so that the ventricles can contract at that one unit that we call the ventricular syncytium. So you can take a look at it here in this image where you have the SA node all the way up here in the upper right corner of the right atrium, pretty much at the junction of the superior vena cava. And then the action potential is going to be propagated through the atrial syncytium, gathered through the junctional fibers, which you really cannot see in this image, and then down to the AV node. So again, there's a little bit of a delay here. Then from the AV node down through that AV bundle to take it down to the ventricles, and then the two branches, the right and the left bundle branch, that delivers the electricity to the corresponding ventricles. And then you can see these Purkinje fibers that start to branch to deliver the electricity to all of the muscles, including the papillary muscles, so that these two ventricles can act as a unit known as the ventricular syncytium. Know that the cardiac muscle fibers are not straight muscle fibers, kind of like you see in skeletal muscles. They are rather these world networks of muscles, so that when the muscles contract, it is pretty much gives you that squeezing or twisting motion. And I'll leave the EKG for its own part.